Chapter 14 covers the components of rehabilitation. Initiating a rehabilitation program involves planning. While healthcare professionals may use many of the same techniques and therapeutic exercises for treating similar conditions, each patient represents an individual case that must be treated appropriately. This includes the understanding that we need to consider the needs of the person before the injury. The old adage, treat the person, not the injury, is true. You are treating someone with an anterior cruciate ligament sprain or ACL injury, not treating the ACL injury itself. There is not a subtle difference. Early in their professional development, students can often find themselves relying on a cookbook method of rehabilitation. These should be avoided. While protocols and common treatments may serve as a guide, students will need to develop their evaluation skills to help set the stage for what the patient needs. Evaluation is a cornerstone of the feedback loop process. An example of a rehabilitation feedback loop is provided on the next slide and on page 302 in your textbook. The feedback loop allows for adjustments and changes to the rehabilitation program. Knowing how to adjust, when to accelerate the program, and when to pull back is what differentiates the rehabilitation professional from someone looking to follow a cookbook. The need for constant feedback and adjustment as the patient progresses to his or her goals is the essence of the feedback loop. Rehabilitation programs can be divided into specific components. Each component can be considered a short-term goal, such as regain strength, reestablish balance, etc. Long-term goals are a big picture goal. These include returning to play to pre-injury health status, daily activity, training, practice, and competition. However, long-term goals may seem farther away for an athlete just out of surgery who has swelling, pain, and limited motion in his or her ankle. To make the program manageable, it is necessary to divide it into specific objectives and sequential steps. When each objective is met, the athlete can progress further in the rehabilitation program. This allows the athletic trainer to build progression in such a way as to guide the patient toward recovery. It is essential that specific criteria be met before advancing in the program. For example, eliminating swelling in the ankle and increasing range of motion before beginning weight-bearing strength exercises. The discussion of prevention, rest, ice, compression, and elevation, or PRICE, stresses the battle line that must be drawn against swelling. Swelling is a common cause of limitation in range of motion. Other items that can affect range of motion include pain, muscle weakness, or an intra-articular obstruction. There are a number of specific therapeutic exercises and rehabilitation skills that are used to assist with regaining range of motion. Passive exercise, hands-on joint mobilization, and active motion exercises, i.e. stationary bike or pool exercises, are just a few tools used to improve motion. At the heart of this rehabilitation component is the need for the athletic trainer to know exactly what is causing the limitation in the range of motion. When the term therapeutic exercise is used, most people tend to think about regaining strength. Strength is a measure of the muscle's ability to exert a maximal force against resistance. Therapeutic exercise is an umbrella term that refers to any exercises used in a rehabilitation program. Several types of strength exercises can be used in a rehabilitation program. Isometric, isotonic, and isokinetic resistance can all play a role. Strength exercises fall under the category of PRE, or progressive resistance exercises. PRE rely on a gradual increase in a muscle's demand in order to achieve a desired outcome. This is the SAID, or specific adaptations to impose demands principle. This principle states that tissues will respond to the demands placed upon them. To get strong, muscles must adapt to increased loads. Following injury, this load may be just the force of gravity as the patient moves through a range of motion. As the patient gets stronger, the athletic trainer must apply manual resistance. The patient may then progress to weight equipment or some other strength device. The key is progression. PRE allows patients to work through a full range of motion and utilize both concentric or muscle shortening and eccentric muscle lengthening contractions. In addition to regaining strength, it is important to address the components of endurance as well as power. Muscle endurance refers to the muscle's ability to perform over a period of time without fatigue. Resistance exercises that are performed using lowering resistance and increased time or repetition help build endurance. Power refers to the amount of work performed over a period of time. Athletes who are powerful tend to be explosive and can generate large amounts of force in a short period of time. A comprehensive rehabilitation program should address all three components, strength, endurance, and power, to best prepare the patient for functional activities and return to pre-injury status. Our central nervous system is constantly taking in information from peripheral mechanoreceptors located in our joints, tendons, ligaments, and muscles. These receptors send information to the CNS that then respond by initiating specific motor responses. Signals sent from the peripheral receptors to the CNS travel what are called afferent pathways. The motor response from the CNS to the muscles travels in an efferent pathway. The relationship between the nervous system and the muscular response that allows for coordinated muscle movement is called neuromuscular control. Proprioception is the ability to determine the position of a joint or limb in space. If patients are injured or immobilized for extended periods of time, they will have proprioceptive deficits and demonstrate a decline in neuromuscular control. If not addressed, these neuromuscular deficiencies can lead to re-injury. Specific exercises that stimulate the mechanoreceptors and cause desired neuromuscular responses are an essential component to the rehabilitation program. Balance is a complex process that involves the integration of muscular forces, neurological sensory information from mechanoreceptors, and biomechanical information. Balance is the ability to maintain our center of gravity, or COG, over a base of support. The range we can move our COG and maintain balance is called our limits of stability. When we move our COG outside of our limits of stability, we must initiate a balance strategy to avoid falling. These strategies include adjusting joint position at the hip, knee, and ankle, or stepping to prevent a fall. A rehabilitation program for a physically active patient should include sport-specific functional training and activities. To this direction, the functional progression is an effective component of rehabilitation program. A functional progression is a succession of activities that stimulate actual motor and sport skills, enabling the athlete to acquire or reacquire the skills needed to perform athletic endeavors safely and effectively. A functional progression for a basketball player with an ankle injury might include riding a bike, walking in a pool, walking on dry land, jogging straight ahead, starting and stopping on the court, starting and stopping while dribbling a ball, getting in a defensive position and moving side to side, jumping to mimic shooting and rebounding, actual shooting and rebounding, progression to full speed drills, progression to actual parts of the practice to full participation. Sport-specific components make up parts of the progression. This method is only one part of a comprehensive rehabilitation approach and should enhance, not replace, the items listed previously. A second consideration under the general heading of function is functional testing. Functional testing and measures of rehabilitation outcomes are used to determine if a patient can progress in his or her rehabilitation program or to determine his or her readiness to return to competition. Functional testing should operate under the guiding principle of specificity of training, meaning that the measure or test should be reflective of the methods used for physical training as well as the demands that will be placed on the patient in his or her chosen endeavor or sport. No rehabilitation program is complete without attention to cardiovascular fitness. Athletes who are unable to practice and compete due to injury will lose cardiovascular fitness rapidly due to inactivity. It is essential that an alternative method of aerobic exercise be introduced into rehabilitation as soon as possible. Stationary bikes, upper body ergometers, and pool exercises are all viable options to address this need. Early initiation of fitness activities may also help motivate the athlete and assist with compliance to the treatment protocol. However, the athletic trainer must be creative and find ways to eliminate the monotony associated with some of these activities. The final component to consider in the rehabilitation program is the decision to return the patient to activity. The decision to release a patient from your care must be done in consultation with the physician guiding the rehabilitation program. The physician will want to see information from functional progressions and functional tests. The athletic trainer must oversee criteria for return to activity. These criteria will contain specific physical parameters such as pain-free range of motion, strength comparable to the opposite extremity as measured in an objective fashion, and the result of a functional physical test. Developing valid and reliable functional tests that can be used for upper and lower extremity injuries is currently an active area of research in sports medicine. To achieve the desired outcomes in rehabilitation programs, the athletic trainer will use a variety of techniques to address the physical limitations or functional shortcomings presented by the patient. In the course of any injury or post-operative treatment, a rehabilitation specialist may rely on any number of exercises to restore and enhance motion, strength, neuromuscular function, and activity-specific movement. While any good athletic training education program will provide students with a foundation of skills to use in the rehabilitation domain, continuing professional education will be essential to stay abreast of the latest trends in rehabilitation. The following techniques are representative of a variety of therapeutic tools available to the practicing athletic trainer: aquatic exercise, gait analysis, joint mobilization, muscle energy, neuromobilization, plyometrics, posture and body mechanics, proprioceptive neuromuscular facilitation, soft tissue mobilization, and sport or activity-specific exercises are all important tools to include in when creating a rehabilitation plan for your patient. In summary, the development of foundational knowledge and skills in the treatment, rehabilitation, and reconditioning domain is an essential component of an athletic training education program. Students completing such a program should be well prepared to practice as entry-level professionals. However, continuing education is a key element of learning and refining skills that can enhance the athletic trainer's ability to address patients' needs and for assessing patient improvements. Proper development of realistic goals coupled with objective criteria to return to activity will provide benchmarks for patient progress.